So, with all of that in mind, from your assessment, you can normally identify a certain number of problems that could include reduced exercise tolerance, shortness of breath or an increased work of breathing, retained secretions or shallow breathing, and reduced lung volumes. And for each of those headings, and this will all be on a handout that will be given to you, there are certain things that you can have in your toolkit that you can use quite easily to try and help with those problems. So if we start off by talking about reduced exercise tolerance, there are a number of things that we can do. We should be trying to promote mobility and exercise with these patients where appropriate, and gauge it on the level that's appropriate for your patient. So can we give them bed exercises, chair exercises, or standing and upright exercises? What level are they? What's appropriate? Use your knowledge that you all have here. Can we teach them some pacing strategies? So there are many different pacing strategies, and some of them just need a little bit of practice and a little bit of exposure. Some of you may have heard of the blow as you go technique, whereby you ask the patient to blow out and exhale on the exertional part of their activity. So fit that in with the exercises, or with sit to stand, or with mobility stairs, whatever it is that you're doing. Encourage regular rest periods so that the patient isn't rushing from A to B and then collapsing in a heap when they get to their destination. If they stagger their activity and just pause for a few moments to relax their breathing and catch their breath, can they get there without feeling so exhausted afterwards? Talk to them about energy conservation techniques. So when they're at home, not just doing that kind of boom bust cycle, getting everything done in one go, can they delegate tasks to other family members? Can they perhaps plan their days ahead, break tasks down, etc.? Anything that they can do to keep them active but prevent them from doing too much all at once. And reassurance is really, really important here. So reassuring them that shortness of breath is normal. When they experience it, they have to try and learn with ways to cope with it and understand that it will pass, but finding ways that will help them to let it settle. So that moves on quite nicely to shortness of breath as a problem to treat. So when we're thinking about our ward patients, we should be looking at oxygen, so making sure that oxygen therapy is being delivered to maintain their target saturations. And if we're thinking about exercising patients, we can consider increasing oxygen for that exercise to maintain their target sats, but just remember to wean it back down again afterwards. We can teach pursed-lipped breathing, so that is where you purse your lips like so, to provide a little bit of airway splinting when you breathe out. A lot of your patients that have chronic respiratory conditions will adopt these techniques anyway, but it's just worth teaching it to patients that don't, because they may find it helpful, they may not. Teaching positions to ease breathlessness is often quite useful. Again, some patients may adopt these naturally, but for those that don't, it can be very, very useful. Lots of patients find the forward leaning position quite useful. You can get them doing it by leaning on their lap, a table in front of them with some pillows. If they're in bed, pillows on their lap. Just be creative. And the aim of this is to offload the abdominal contents from the diaphragm to hopefully help reduce their work of breathing and reduce their reliance on their accessory muscles as well. Likewise, you can then utilise that when they're up and mobilising. So can they lean forwards on their lap when they're standing, on the knees, or can they lean on a wall or a surface to have a little rest halfway through when they're pacing themselves. We can try a couple of methods to help with reassurance. We have a few leaflets on the ward for calming hand and the breathing square. These are just kind of relaxation techniques. The leaflets are fairly self-explanatory, so they're fairly straightforward to teach, but lots of patients find them useful as they're things that they can then go on to do to self-manage. And lastly, with shortness of breath, secretion clearance as necessary, which is a really, really important one. We'll move on to retained secretions now. Where able and appropriate, we should be mobilising these patients as a first port of call, and this is gold standard for secretion clearance. So if they're able to and they're medically stable enough, try and mobilise them in the first instance to try and allow them to clear their chest independently. However, if necessary, you can then move on to the next steps. If they're not so mobile, rolling and repositioning them in bed is the next thing to try. And with positioning, it will depend on what the problem is, so whether you think they need to be in an upright high sitting position or perhaps inside lying. We can then go on to try ACBT, so your active cycle breathing technique. Again, we've got leaflets and booklets on the ward that go through this step by step for patients, but just as a bit of a refresher, there are a couple of main components. The first one we'll talk about is breathing control, and this is just a nice, gentle, relaxed tidal breathing. It's often used standalone to help patients recover from their shortness of breath. You want to ensure your patient's in a nice, relaxed position. You can ask them to pop their hands just above their tummy to just notice their breathing. You'll want to make sure they're comfortable and just allow that breathing rate to settle again. And once that is the case, then move on to thoracic expansion exercises or your deep breathing exercises. The aim of this is to aid with collateral ventilation. So again, you can pop your hands on the patient's chest if they need a bit of feedback. So you're going to want to ask them to take several deep breaths in through the nose, out through their mouth if able. If unable, breathing in through their mouth is absolutely fine. And you'll want to ask them to breathe in as deeply as they can, and they should try and shift your hands outwards if they're needing that hands-on for feedback. So try several thoracic expansion exercises, then go back to breathing control to settle things out again, and then you'll want to move on to your forced expiratory technique, or your huff as they are better known. So this is a short, sharp breath out through an open mouth, so it's a huff, and you can do these from different volumes, so a short, sharp huff or a longer, slower huff, and the aim of the huff is to mobilise secretions from distal to proximal, so that they're higher up, so that a patient's cough is more effective. So then you'll want to finish with some coughing. So before you start, make sure that you have things nearby as needed: tissues, bowls, sputum pots if anyone needs a sputum sample. ACBT is great because it can be done in any position, whether a patient's up and mobile, in bed, in the chair, it doesn't really matter. And then you can try and teach the patients to do it themselves as part of their self-management. Moving on, consider nebulizers and oxygen therapy for helping with retained secretions. So if a patient isn't on any nebulizers and you're noticing that they're clearing quite thick, sticky secretions, we can recommend that they be started on some just general saline nebs. Oxygen therapy, if they're needing anything above 4 litres for more than 24 hours, we should be considering switching their oxygen to a humidified circuit to help prevent drying out their airways, to make it more comfortable for them and to try and loosen their secretions. So we can switch them to a cold humidified circuit. Manual techniques are also really, really useful. So these are your expiratory vibrations, chest clapping and percussion. If you have had experience in doing so. If you haven't, then I'd probably suggest just speaking to a member of staff that has, as you'll want to make sure that they don't have any contraindications before you start treating. And then lastly, again, if trained and it's within your scope, you can use other adjuncts such as suctioning, cough assist, your bird and a cappella if appropriate. Again, this will definitely need to be within your scope because you'll have to be weighing up with clear clinical reasoning and checking for contraindications. And the last problem that we'll talk about treatment options for is shallow breathing or reduced lung volumes. So we want to kind of establish what the cause is. If it's pain, make sure their analgesia is optimised first before you go and see them. Wait that 20 minutes and then return, see if there's any change. If they're breathing quite shallow because they've had an operation, they're post-op, can you teach them a supported cough? So using a rolled up towel or a blanket to just support and then reassure them that coughing isn't going to cause any damage and that it's important and necessary. Again, as with all of the other topics, promote mobility and exercise as able when appropriate. Teach deep breathing exercises, and again ACBT is really key within this topic. Optimise their position, so we ideally want them sat out in the chair and mobilising, but if for any reason they have to stay in bed, upright high sitting is really, really good. So just lastly, some important things to consider. You'll want to be monitoring your patient's observations during your treatment, particularly if you're doing anything to do with secretion clearance and for patients that are already on higher amounts of oxygen, you'll want to make sure that they're maintaining their sats and that we haven't done anything to cause desaturations, and if that is happening, then we need to act upon that very quickly. You'll also want to be looking for things like cardiovascular instability as well, so keep a close eye on those things. Other important things to consider are feeding back to the MDT when we've finished our treatment for these patients, so handing over things to the nurse in the bay, speaking to the doctor afterwards. If you're concerned about patients, escalating things to senior doctors, senior members of staff. Escalate a patient to a respiratory trained physio if you feel they need any treatment that is outside of your scope, or if you've tried things and you're worried that a patient is deteriorating or needs more input. When you're escalating to doctors, if you're concerned about a deteriorating patient, it's really important that you use the ISBAR method of communication. So introduce yourself, explain the situation, the background, your assessment and recommendations, and this just helps ensure a kind of effective communication style and gives them the best chance to respond to what you're asking them to do. If you are really concerned and a patient is for full active treatment and you're not able to speak to a doctor for whatever reason, you can always contact the critical care outreach team to discuss any concerns as well. Obviously try and speak to the doctors that are on your ward first, but in an emergency, if you're unable to, they are another team that you can contact. Thank you very much.